COIN, Community-Oriented Integration Network, is a network of friends, people of experience, who explore how to develop local communities for health, compassionate communities. This video describes our conclusions about how to do this at scale within local geographic areas that we might call neighbourhoods. This video includes our conclusions about how neighbourhoods can become compassionate communities. We think that the government's plan to develop out-of-hospital care through neighbourhoods presents an opportunity for high-quality, low-cost care by enabling collaboration as equal partners between health workers, care workers and everyday citizens. Now, this won't happen just by wanting it to happen. It requires the application of the science of community development. COIN has got a lot of people who understand this. The difficulty of achieving local integration is well known. At the 1978 Alma Ata Conference, 134 countries agreed that medical practice needs to be integrated with other efforts for health to achieve strong or comprehensive primary health care, but poor understanding of how to do this has prevented it from happening. To make compassionate communities, to avoid NHS collapse, the science of how you arrange, facilitate, make happen comprehensive integration at local level needs to be understood and to inform the NHS plan. The science of community development, helping people to work with each other for health and care at local levels, is rarely understood, rarely taught, rarely applied, and it's not exactly straightforward. COIN includes people from different parts of the world who know more about this than many others. In the 1980s, COIN members led the Association of General Practice in urban deprived areas in England, facilitating intercity learning about integrated working. In the 1990s, through fund-holding, primary care facilitation programs and research networks, we explored different ways to sustain integration. Between 2008 and 2018, we led London Journal of Primary Care, which distilled the concept of community-oriented integrated care that we revised in 2022 to community-oriented integrated practice, to denote that individual caring actions are not enough, and the science of community-oriented integrated practice needs to be understood and applied everywhere. Community-oriented integrated practice recognises that everything is co-adapting to changes in everything else. This means that medical insights need to be seen as snapshots of complex stories in evolution. Protocols need to be seen as food for thought, not absolute truths to be transactionally applied. Previous inattention to processes of co-adaptation has obstructed collaboration. It has allowed atomised, linear thinking to dominate policy. This has resulted in reduced capacity of local government to develop compassionate communities, social services preoccupation with safeguarding without the skills to help people to develop supportive relationships around their situations. Specialists who ignore things that fall out with their specialist training processes, and GPs who lack the skills and incentives to consider social and contextual factors beyond or behind the complaints or symptoms with which individuals present. It results in researchers who fail to recognise that knowledge is context dependent and training and teaching at all levels of education that is focused on straight lines at the expense of understanding complexity. It results in carers who lack support from and integration with statutory services. The good news is that all of this can be changed by adding the ideas of complex co-adaptation. Neighbourhoods could play a key part in changing this by promoting shared developmental spaces. They often already exist in schools and faith groups, music and exercise clubs, sports events and festivals. But we can highlight their potential for for people to use them to learn to appreciate each other and collaborate for the greater good. The homes where carers live are particularly valuable for health services because they're developmental spaces that are shared by patients and carers, health and social care practitioners, families, friends and many others who are often more prepared than usual to collaborate for health and care across boundaries. When someone is sick or somebody is dying, it does make people often feel ready to work together. For I's to become we's, individuals to become communities, people need to creatively adapt to each other through shared adventures, shared vision, shared stories. This co-evolution is invisible to evaluation that assumes that the world works only in transactional, compartmentalized ways. Fourth generation evaluation from Guber and Lincoln gets past this limitation through repeated stakeholder reflection on different kinds of data in the light of their lived experiences and multiple inputs. For example, in a neighbourhood, data of hospital admissions and places of death amalgamated for that area could help local people to discuss the value of different strategies for carer support. Ongoing facilitated debate between case studies, for example neighbourhoods or cities, informed by different kinds of data could be a winning strategy. It's relatively easy to organise. It witnesses, in real time, tangible outcomes from collective efforts. It emboldens people to lead multiple micro changes to improve quality and cost effectiveness. It develops facilitation skills in local populations to build trusted relationships and compassionate communities. Neighbourhoods could also help to re-enthuse general practice by providing opportunities to treat discrete diseases in the context of human things, family, community, environmental health. In 2024, COIN brought together 5 different initiatives, each of which is trying to develop the idea of community-oriented integrated practice in different parts of the system. Anglia Ruskin University is developing its medical school curriculum, helping the university to become part of the local fabric of society, recruiting local people, working with schools and colleges and preparing medical, nursing and other students to provide whole-person, team-based care with appropriate communication, reflection, evaluation and relationship skills. London RCGP faculties, that's the Royal College of General Practitioners, will hold a City Health Conference in June 2025, at which primary care practitioners will explore the theory and practice of community-oriented integrated practice and see how general practice can develop a leadership role in this holistic thinking. The Complete Care Community Programme is supporting 65 primary care networks, that is, coalitions of general practices in approximately 50,000 population, to pilot next stage thinking in locality-based, relationship-based practice. In Brent, a carers course is being developed as a collaboration between Brent Carers and Central London Community Health, piloting a course to help carers take their place in community-oriented integrated practice, acting as a focus for collaboration between different disciplines and a place to integrate the activities and work of people in the local areas. And in Liverpool, in collaboration with the Liverpool School of Tropical Medicine and places in Africa, including Kenya, citywide collaborations, developing shared leadership for health and care, involving the active participation of local communities, creatives, city council, public health, primary care networks and others to facilitate whole city collaboration for health and care. Leaders of all these initiatives recognise that the disconnect between social services and the NHS is a major obstacle to quality and cost containment. So is the disconnect with faith traditions, with public health, with ecological groups, with economics. These major sections live in isolation largely from each other and need to be reconnected. Interdisciplinary collaboration at more central places is also needed, including government. To enable local collaboration, you need to model this in more central places. People need to learn how to think horizontally as well as vertically. One of the difficulties with developing communities for health and care is that the language to describe it can often sound like jargon or academic or too difficult to follow, words like complex co-adaptation, for example. On the other hand, images can reveal this complex co-adaptation in ways that make it look like common sense. The image that follows shows how neighbourhoods can become compassionate communities. It reminds us that to value other people's perspectives and develop community spirit, people need to creatively interact with others, helped by umbrellas that shield them from the rain of everyday demands. Good facilitation helps participants to look outwards for the common good, rather than the common tendency to look inwards, reinforcing existing prejudices and acting in selfish ways. Policy can develop facilitation skills and pathways between different umbrellas that help different groups to shape collaborative projects that shape the whole of that area, developing a culture of collaboration, co-adaptation, becoming compassionate communities. What do you see in this image? Do you identify with the overwhelmed person on the left, or the competent multitasker on the right? Do you recognise the need to go under umbrellas from time to time and talk to people about deeper things than your daily demands? Do you recognise how dangerous it is to imagine that the one umbrella is the only umbrella? Indeed, we need to be able to go between different places, dipping in and out of other people's lives. And do you see the box in the bottom left-hand side, full of secrets, the things that aren't allowed to be talked about? And do you see this box being opened underneath an umbrella, a place where you've developed trust and understanding with others, a place where stories developed, where ideas are developed, where creativity and innovation comes from. The COIN planning team is multidisciplinary. The COIN network is multidisciplinary, coming from different parts of different systems of different countries. The unifying thing is a belief that you do not have to control and dominate and conflict against others in order to create good things. You need to listen and co-adapt. And how you look at things alters what you see. If you intend to look for a machine, you will see a machine. If you intend to see organic growth, you will see that. Both of these lenses are useful. One does not dominate the other. They provide different insights into the whole.